Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting head and neck case of the day. So as always, I'd like to start out by stating that all of the educational content found as part of this presentation has been completely de-identified to protect patient privacy. So the history in this case is a patient who came in with otalgia and otorrhea. And I've got four images for you to take a look at. Top left, we have an axial T1 weighted image. This is a pre-contrast T1 image. Top right, we have an axial T1 post-contrast fat-saturated image. The image on the bottom left, we have an axial non-contrast CT through the same level. This is a bone algorithm reconstruction. And then the image on the bottom right, we have a coronal haste diffusion weighted image, so a non-echoplanar coronal diffusion weighted image. So again, history, ear pain and drainage, four images to look at. Try to put it all together. Okay, so what are the findings and what's the diagnosis? All right, so as we take a look at our axial T1 weighted image, what should become readily apparent is we have a submucosal mass that's located in the medial bony external auditory canal, denoted here by this yellow arrow. Now we're down low in the EAC. You can see we're at the level, we're seeing the mandibular condyle. We're down, you can see sort of in the infrazygomatic masticator space and carotid space. We know we're down low in the external auditory canal. Now this mass has intermediate T1 signal intensity. And if you look carefully, you can see that the bony external auditory canal has a bit of a scooped out appearance. It looks like something is eroding it out. So anytime that we see something that may be a mass in the head and neck, we always want to give contrast. So here's our axial T1 post-contrast fat-saturated image, and you'll notice that this mass is effectively non-enhancing. Now, there is some adjacent mucosal hyperenhancement. You can see denoted here by the yellow arrow. It sort of extends to the margin of the mass, but the mass itself is non-enhancing. And so that sort of look is suggestive that perhaps there's surrounding inflammatory changes going on. Well, as we look at our next image, this is our diffusion weighted image. You can see on this coronal haste or non-echoplanar diffusion image that this lesion is light bulb bright, denoted here by the yellow arrow. So what are your thoughts on the diagnosis? Hopefully the general diagnosis here anyway, should be readily apparent. But what's unique about this, about the location, and when we see it here, is there anything else that needs fleshed out more in your report? Anything else that we want to report to the ordering docs? The last image to look at, we have our axial non-contrast CT image. Again, we see that we've got this submucosal mass in the medial bony external auditory canal, denoted here by the yellow arrow. But again, take a look at that bone, that subjacent bone. That's getting eroded out. You can see that scooped out appearance of the bone. And where is this extending into? It's extending through the bony EAC wall into the mastoid. And that's an important thing that you want to report for the surgeons to be aware of. So, in this case, what's our diagnosis? This is an external auditory canal cholesteatoma. Cholesteatomas are non-neoplastic but locally aggressive masses. And I'll call them a mass because it occupies space, but it's non-neoplastic. It's not a tumor. These masses are made up of exfoliated keratin within a background of stratified squamous epithelium. Now, these can occur spontaneously, and that may be due to abnormal EAC ectodermal migration. They can be secondary, either to trauma, or sometimes you'll see it in an iatrogenic setting. And that can also be congenital, and when they're congenital, that's very rare, but it can be seen in the setting of an external auditory canal malformation. So hypoplastic EAC that doesn't want to exfoliate in a correct manner, and you sort of get that keratin getting trapped there. So interestingly, on clinical grounds, these look different than middle ear cholesteatomas. They're not that pearly white appearance that we frequently associate with middle ear cholesteatomas, but rather these are oftentimes darker and more waxy in appearance. And they may have a variable degree of bone erosion. And that's important for you to report because that helps to dictate the management. If these aren't really eroding the bone or if it's sort of minimally eroding the bone of the EAC, they may get by with just doing periodic debridement. But in a case that it's sort of going transosseous into the middle ear mastoid, that makes surgical excision, a formal excision of this cholesteatoma, much more likely for appropriate management, because these will continue to recur. And if it's already going transosseous and invading into the middle ear, this could be a setup for something much more difficult to control or to maintain control over. Okay, so EAC cholesteatomas, what do they look like on imaging? Well, on CT, they're erosive. You really shouldn't be swinging hard for the fence on the diagnosis of cholesteatoma on a temporal bone CT unless you see bone erosions. That's kind of a hallmark telltale finding. These are soft tissue density. They'll appear mass-like, and these are going to be centered in the external auditory canal. Now, just like this case showed, these typically are going to spare the tympanic membrane. If they get into the middle ear, it's because they've eroded through the bone rather than it spreading through the tympanic membrane. That's different than the other cholesteatomas that we commonly think about, the pars flaccida and pars tensa, which are much more intimately involved with the tympanic membrane. So that can be an important thing to keep in mind. You may see internal flecks of bone within that soft tissue substrate of the cholesteatoma. And that's a really nice distinguishing feature when you see it. But as this case showed, we don't always get that. And that's where CT and MRI can be quite complementary. So if you see those internal bone flecks and an erosive soft tissue mass centered in the EAC, you can feel quite confident that you're dealing with an EAC cholesteatoma. Yes, of course, they need to directly visualize. Yes, they probably should send it to histopathology to make sure, to confirm that diagnosis, but you can feel quite confident in the diagnosis when you see those internal bone flecks. If you don't see them on CT, then it gets to be a little bit more challenging. It still could very well be a cholesteatoma, but you do have to make sure that it's not a malignancy or a neoplasm growing there. So that's where MRI can play a role, quite a nice complementary role. As this case showed, these are non-enhancing tumors. I slipped. They're not tumors. These are non-enhancing, non-neoplastic masses. But they tend to be T1 and T2 intermediate, and they will have characteristic reduced diffusivity. So they'll be light bulb bright on diffusion imaging, and we tend to see that much better on the non-echoplanar prep diffusion sequences. All right, a little bit about staging that sort of relies on a combination of clinical imaging and histopathologic categorization. Stage 1, these are very superficial lesions. They may be associated with some epithelial hyperplasia. Not something that you're going to see on any type of imaging to confirm that, but histopathologically they can confirm it as a stage 1. Stage 2, you may see some periostitis. That again is something that histopathologically can be confirmed much more accurately. Now when it gets to stage 3 disease, then you start having erosion of the bony external auditory canal, something that you can readily identify on CT imaging. And then stage 4, as this one was, the lesion is extending into the adjacent bony structures. It's invading, in this case, into the mastoid. So again, I don't talk about the staging of these in my reports, but it's helpful to think about it as you're approaching your thought process of what do I need to talk about. Obviously, you want to talk about bone erosions, but especially if this is becoming transosseous, as this one was, getting into the mastoid middle ear, that's clearly something you want to report because those patients are much more likely to need a true formal surgical excision rather than in-office debridement. Here's a nice paper we're taking a look at. This was by Challa and colleagues, published in Current Problems in Diagnostic Radiology in 2015, but it's a nice pictorial review of external auditory canal cholesteatomas. So for all the residents and fellows, this is a nice paper to take a look at for a nice overview. Okay, so to wrap this up, this was a patient with an external auditory canal cholesteatoma. The key imaging features that we showed in this case, this was a non-enhancing submucosal mass, and it's a mass, as I said before, it occupies space, but it's non-neoplastic. This is a non-enhancing submucosal mass in the medial external auditory canal. We had subjacent bone erosion and even transosseous extension into the mastoid in this case, and then that hallmark reduced diffusivity light bulb bright appearance on the non-echoplanar diffusion sequence. There are some pearls and pitfalls to consider with cholesteatomas in the EAC. If you look at textbooks, these are typically reported as a unilateral finding, and that's the case in the majority. I have seen Now, on multiple instances, I have seen bilateral external auditory canal cholesteatomas. So if you see a unilateral lesion, that sort of helps you to convince yourself that you may be dealing with an EAC cholesteatoma. Just know they're not always a unilateral finding. On rare occasion, you'll see them bilaterally. That's in contradistinction to keratosis obturans and medial canal fibrosis. A couple of other soft tissue attenuation EAC lesions. Those are much more commonly going to be bilateral. Those hallmark bone flecks that are often attributed to EAC cholesteatomas, keep in mind, while those are frequently present, they're not always present, and this is a case that did not contain any. So when you see the internal bone flecks, that can be very helpful in sealing the deal that you're dealing with a cholesteatoma, but they're not always present. In this case, they were absent. And that's where MRI can play a useful role as a complementary tool in assessing these, because it gives you more information about it. And the non-echoplanar diffusion sequence is very, very, very sensitive for detecting cholesteatomas. One last thing to drive home this point one more time. Make sure to report the extent of bone erosion, because that may make the difference between a patient who goes for sort of routine, periodic, in-office debridement of an EAC cholesteatoma versus someone who needs a formal surgery for a more wider excision of the cholesteatoma component. So always talk about what you think the diagnosis is, but also think like a surgeon. Where's it going? What's it doing? Lay the groundwork for them. Give them a roadmap, a blueprint for their surgical management. So as always, thanks for tuning in to IU Radiology Case of the Day. I'd encourage you to follow along on Twitter at NACoontz, and you can check out our complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.